Hello. It's time for the best lesson of every single unit, the one about our diseases and trauma and basically what can go wrong with the body. So let's dive in. This whole unit of the cardiovascular system really all comes down to one particular thing working well, and that's perfusion. Perfusion is the constant flow of blood to the tissues. We want that constant flow because blood carries oxygen, and every single one of your cells needs oxygen in order to make ATP or energy. If I have poor perfusion, I'm not getting enough oxygen to all my cells, and my cells essentially will start dying. So every single problem, or not every, almost every single problem that we're going to deal with the cardiovascular system, we want to focus on, are we maintaining a constant flow of blood to our tissues? And there's three components of good perfusion, and they call it the perfusion triangle because three sides make a triangle. So you have to have a functioning pump. Your heart has to be working properly. You have to have functioning blood vessels, meaning your blood vessels have to be the right size. And we'll explain why that's so important in a later slide. And the last one is the blood itself. If your blood is not carrying oxygen properly, if you don't have enough blood, that's all going to lead to poor perfusion. So you have to have all three of these components working together in order to get the proper amount of oxygen to your tissues. One of the main issues or diseases with the heart that is probably the biggest that we face in our modern world is atherosclerosis. It's the hardening of your blood vessels because you're building up a plaque inside of them. And plaque is just a mix of calcium and fat that starts to harden. Well, this normally wouldn't be a problem, except our blood vessels can only get so big. And after a while, that space for blood to flow through the heart gets smaller and smaller and smaller. And it can potentially lead to a complete blockage where no blood can pass through at all. We call this an occlusion. And if that happens in your coronary artery, we've learned that it can cause ischemia, the lack of blood flow to the heart, which can lead to a myocardial infarction, a heart attack. So the best way to prevent this buildup is to maintain a good diet and exercise. You want to make sure that you're getting your cardiovascular exercise in to keep your heart healthy and strong. And you don't want to eat a diet high in saturated fats. You want to eat a diet that has a lot of plants in it, a lot of things that are good for your heart, and basically, just moderation for everything. You can have a steak every once in a while, but not every single night. The next thing that we're going to talk about are aortic aneurysms. These are big, scary guys. An aneurysm is a weakness in the walls of your aorta or your vessel. So the walls themselves are essentially, they're stretchier than normal. And so they will actually start to bulge, like you can see in these pictures here. Now, any weakness in the walls is a place where you can possibly have a rupture or a tear. So these can literally burst and cause you to bleed out internally. We talked about them a little bit when we discussed strokes. You can have an aneurysm in your brain that leads to a stroke occurring. Now, with aortic aneurysms, you have a worry of prolonged hypertension. If you have an aneurysm and you have high blood pressure and that blood pressure stays high, it's not like, oh, I went and worked out for a little while, so my blood pressure went up. This is a constant living with hypertension. That can cause your aortic aneurysm to rupture. That extra pressure of the blood flowing through there can be too much for those weak walls and it can burst. So what is this going to present like if you're working with a patient who has an aortic aneurysm? If it does happen to burst or is close to bursting, they might complain of very sudden, very, very strong pain in the anterior chest, in the front of their chest. or they might feel it back between their shoulder blades. That's a big thing that makes it different from a heart attack. When you have a heart attack, it stays in your chest, whereas this one can then move to your back. Another difference between the two is what the pain will feel like. If you have an aneurysm that's bursting, the patient is going to say, it feels like something's tearing inside of me. It's really sharp, and it doesn't start getting stronger and stronger over time. It's just sharp. Whereas a heart attack, it's going to feel like somebody's standing on your chest or sitting on your chest. It's a pressure, and it's going to get worse and worse over time. Nothing's going to be able to alleviate it. And when you're looking at a patient who has an aneurysm, you might notice that they have different blood pressures between their two arms. They might have weaker pulses in their legs or just in any of their limbs. But the horrible thing is, because this is your aorta, which is the main vessel, the main artery coming off of your heart, feeding your whole body, if this thing were to blow, that's all of your blood coming out of your heart that's now suddenly flooding your body cavity and not getting where it needs to be. So you often end up having the patient die as soon as it ruptures. If you do happen to have a patient who comes in who's complaining of this, this is one of those emergency situations. They need to get into surgery as soon as possible to save their life. The main thing that we're going to talk about relating to the heart is shock. You've heard that probably a lot in movies and TV, and it's not like, oh, I've had a shock, I'm scared. This is an actual medical term that's related to hypoperfusion. So hypo means below, and hyper means above. So this is hypoperfusion. So perfusion is less or below what we want it to be. We're not getting enough blood to the tissues with the oxygen that's needed to keep them alive. It's essentially a state of cardiovascular system collapse. Your cardiovascular system is failing. The earlier stages are going to be characterized by something called compensation. Your body is going to be trying to make up for the loss of blood or the thing that's causing your shock. Over time, though, you can't compensate anymore, and your body's going to start to crash and your organs will start to fail. So what are some of the causes? There's a lot of them, but remember, it all comes back to that perfusion triangle. Is my heart working properly? Is my blood working properly? And are my vessels working properly? If any one of those fails, you can end up getting shock, hypoperfusion occurring. So we've talked a lot about the heart failure ones, something like a heart attack. We've gone through a lot of those, so we're not going to spend as much time as we will on the vessel failure and the blood failure. But basically, any of these failures is going to lead to poor perfusion, and you can get shock as a result. So the overall categories of shock, you can have hypovolemic. So this is saying that my volume of my blood is too low. So you can be hypovolemic when you're bleeding internally or externally. We'll get into more examples of those in a second. You can have cardiogenic shock, where there's a problem with the heart itself, your pump is failing. Obstructive shock, this is going to be something else, an obstruction that's causing your heart to fail, or your heart to not work as proper, or your heart to not work properly anymore, excuse me. And then there's distributive shock. This is distributed across your whole body. All of your blood vessels are going to dilate nearly simultaneously, and there's a bunch of different examples in this one that we're going to go through. So the first one, hypovolemic shock. This is probably the one that we think of and we see the most in movies and TV. If I am bleeding, I am going to go into shock if I lose too much blood. So hypovolemic is the loss of fluid volume. Now this can be blood or plasma. So you can actually lose red blood cells, Or you could be dehydrated from chronic diarrhea or vomiting from something like cholera. You can end up having hypovolemic shock because of some other disease that you have. So it's not always just related to a cut that you're massively bleeding from. The ones where you are bleeding, that's hemorrhagic. The one where it's something else, you don't see the active bleeding going on, that's non-hemorrhagic. Things like internal bleeding, vomiting, diarrhea, even burns. Because when you lose that keratinized layer of skin all over your body, remember, the only reason why not one of the only reasons, but one of the reasons why we have the keratin is to create a watertight seal on our body. So when we lose the keratinized cells of our skin, we're now going to be losing a lot of our internal water as it evaporates out of our body. And you can end up having massive dehydration as a result. We can lose about a liter of blood, but you're going to see that it's particularly worse for young people or old people because they have a harder time regulating their blood volume, or they just have less blood volume. So a loss of blood is going to be a lot more dramatic for them. And when you have hypovolemic shock, you often want to treat people by giving them fluids. You want to replace the blood volume that was lost, or you need to control it with surgery or pressure on the wound, something to stop them from bleeding. So if it's external bleeding, our body can survive if we lose about 20% of the volume. Anything after 20%, you're going to start to go into shock. And that's about equivalent to 1 liter. Now, children, they hit that critical point after losing about 100 to 200 milliliters of water. That's not a lot at all, or blood or water, fluid from their body. So you can see that even a small loss of blood can be really traumatic for a young body. Now, normally we clot our blood, and that prevents us from having massive internal bleeding or external bleeding. Within 5 to 10 minutes, you usually have a nice good clot and the bleeding is done. But sometimes the tissue damage can be so extensive that we can't form a clot. And those are the times where it's really important to get the bleeding under control. Mostly, you're just going to want to apply pressure. The more you press and keep the blood from escaping, the more likelihood that that clot can form. Now, sometimes you need to have more drastic measures, and that's when you'd want to use something like a tourniquet. And these are to control really excessive bleeds in the limbs. Medicine goes back and forth on tourniquets and whether or not they're useful or the right thing to use. But one of the things that we've noticed, having been in the Iraq and Afghanistan wars for so long, is we've saved a lot of military lives from the quick administration of tourniquets to limb wounds. So right now medicine is trending back towards, yeah, tourniquets are good to use in the event of a massive trauma to a limb. But the way you want to use them has to be very specific. There's a few do's and don'ts when you apply a tourniquet. You want to apply it above the wound, meaning more proximal to the body. You don't want to apply it on the wound itself. So as you can see in this picture here of the person's leg, this is the knee, so their foot would be somewhere over here. You want to apply the tourniquet above the bleed. Same thing on this example down here. Another thing that you want to make sure you do is make sure it's really, really tight, because if any blood can still leak through, you're going to end up with continued bleeding. So this is going to have to be a seriously tight tourniquet. You also want to avoid using anything that can cut the skin. So you don't want to use a really small rope or a sharp wire, obviously, but it's still good to be told. And then another thing you don't want to do is you don't want to put it directly on a joint. So you don't want to put it on your elbow. You don't want to put it on your shoulder or under your knee. You want to keep it in an area where there is no joint. And you also want to keep it closer to where the wound is. So if you have a wound in your forearm, you don't want to put the tourniquet in your upper arm really close to your shoulder. You want to keep the tourniquet as close to where the wound is as you can, with still giving yourself a good distance so that it's not covering the wound. Once you put a tourniquet on, you do not loosen it until a medical professional loosens it. So you don't want to, oh, well, let me check to see how this is going and loosen it, because then you're going to make the patient continue to bleed out. So just leave it on until a doctor can get to the wound, and then they can take the patient directly into surgery. Now, internal bleeding, there's not much you can do if you're not already in a hospital setting. It can be caused by illness, like if you have an ectopic pregnancy that ruptures, or an ulcer that's starting to bleed, or an aneurysm, or you can have the traditional trauma, like a car accident that you think of that might cause internal bleeding. You'll see the darkness that looks like a huge bruise on the body. Sometimes it can get really black looking. You will have altered mental status, altered level of consciousness. That's a big one. If you're bleeding internally, it's going to be very similar as if you were bleeding externally, except you can't see the blood. So you have to look for other signs. The person might be confused. They might feel really faint and dizzy and tired. They might not be able to know tell you where they are. So that altered consciousness might be the first sign that you have to notice that there's internal bleeding with the patient. They might be really pale. They might have clammy skin. Another thing is that they might complain of tenderness. It might really, really hurt if they touch their abdomen or their arm or wherever the internal bleeding is occurring. Now, there can be external signs of internal bleeding, and they're usually not good ones. Things like vomiting or coughing up blood, or blood in the urine. These are really bad, obviously, and if it ever happens, you want to get to the doctor as soon as possible, especially if you're ever coughing up what looks like coffee grounds, or if your stool is really black and tarry. That's indicating a bleed in your intestinal tract, and you want to get that looked at right away. And usually these are treated with surgical intervention. Now let's go into cardiogenic shock. This one we're not going to spend a lot of time on because we discussed AMIs and issues with the heart in a previous lecture, but the cardiogenic shock occurs when the heart can't pump properly. Either you got a disease and a virus is affecting your heart, or you've had a heart attack. Basically, the heart muscle itself is not doing the right job to pump blood through your body. So if your heart isn't pumping, that's one side of the triangle that's failing, and now you're going to have poor perfusion as a result. Obstructive shock is related to the pump itself as well. So this is still dealing with problems with the heart itself and the heart not being able to pump blood properly. Usually this is because something is blocking the heart's ability to pump. Something like an embolism, a clot. Something like the pericardial effusion or the cardiac tamponade that we talked about, where there's fluid or blood filling that pericardial sac. The new one that we haven't talked about are these pneumothoraxes and hemothoraxes. A tension pneumothorax is when you have some kind of damage to your lung that prevents air from flowing in and out of your lung properly. And now there's going to be air filling your chest cavity. So there's air outside of your lungs. We call this a collapsed lung often. And what will end up happening is your body, your chest cavity there will continue to increase with air. It'll start to fill with a lot of air, and that will start pushing on the rest of your organs. So you can see in this picture here that the heart is misplaced. It's actually being pushed to the side because of all the air, that air pressure inside the damaged lung area. You can see that here too. The lung has collapsed, and this whole area is being filled with air now, and it's causing the heart to be displaced. So if your heart is having pressure from the outside placed on it, it won't be able to pump as effectively. It's going to be blocked from pumping normally, and you're going to end up not pushing as much blood out, so you have poor perfusion. Now, distributive shock. This is where your blood vessels suddenly dilate, distributed throughout your body. That's why it's called distributive shock. So when your blood vessels dilate, they get wider. You don't get more blood though. So your blood volume stays the same, but suddenly your blood is in a much bigger container. So the blood is going to now pool and not be able to move through those vessels the same way as it was before. So your blood is then going to not perfuse well. You're not going to get blood to all the tissues adequately. And there's a few different types of distributive shock that we're going to talk about now. The first one is sepsis. So you can go into what's called septic shock. This is where you have a bacterial infection that's maybe not going away, you've had it for a long time, or it depends on where you have that infection. And the infection then spreads and the bacteria get into your bloodstream. Now the bacteria are going to be able to multiply, they're going to be able to invade other parts of your body, so you have a full body bacterial infection. And what will happen is the bacteria can start releasing toxins, and that will end up causing your blood vessels to dilate. They get larger. When that happens, they also become leaky. So you're actually going to be losing blood plasma from your vessels because they're so big and leaky. So you're having distributive shock because now all of a sudden all your blood vessels dilate, and you're experiencing hypovolemic shock because you're losing plasma from your blood vessels. This type of shock requires fluids and antibiotics. So you want to get IV antibiotics in right away because this is a massive infection and you need to have the big heavy hitters to stop it. And you're going to want to replace any fluid that's been lost out of the bloodstream by giving the patient an IV of fluids. This is where I kind of get on a little soapbox here about our antibiotics. When you take antibiotics that you haven't been prescribed, or you don't take them exactly the way the doctor says, you can end up contributing to the problem of antibiotic resistance. So now you need stronger and stronger antibiotics to be able to fight infections. And eventually there's a hypothesis that there's going to be a superbug, one that no antibiotic can fight off. So try to only use antibiotics when you really need them. You don't need antibiotics for a cold. It won't help with allergies. They don't help with viruses. They only help with bacteria. It has to be something living. Antibiotic means anti-life. So bacteria are living cells, viruses are not. So it only works on the bacteria. The other type of distributive shock that we're going to talk about here is psychogenic. So this is where something scares you. You hear a big loud noise and the person faints. Basically, some kind of response in your neurological system causes all of your blood vessels to dilate nearly simultaneously. You lose blood pressure, and that causes you to faint. Your blood can't be pumped back up to your head properly, so you don't have enough oxygen getting to your brain, and you pass out. Normally, this is just temporary, and you wake up fairly quickly afterward, but it can be a symptom of an underlying problem like an aneurysm in your brain. So normally you don't need to be treated for these, but if it's happening a lot, maybe you should go see the doctor about it. For distributive shock, we also have neurogenic shocks. This is the third of the 4 kinds of distributive shock. This is where you've had damage to your spinal cord. The higher up in your spinal cord, the more likely you are to have a problem with your baroreceptors, the ones that control your blood pressure. So if you have damage to your cervical vertebrae, the ones right up in your neck, you can end up having massive widespread blood pressure failure. All of your vessels dilate, you can't keep your blood pressure up, and you're going to have shock as a result from that poor perfusion. Usually this is due to trauma. You've broken your neck in a car accident, or you've fallen, something like that. However, if you have a tumor pressing on that part of your spinal cord, the same thing might happen. With this one, because it's affecting your nervous system, you may see hypothermia, because not only are your baroreceptors being affected, but all the other systems of your body may be affected as well if your nervous system can't control them. So you're going to have a really hard time regulating your temperature. You're also not going to be sweating. So this patient will be very dry to the touch. They won't have any sweat at all. With this one, the key thing is you want to stabilize their head and neck. You want to make sure that you don't do any further damage to the spinal cord in case that the damage isn't permanent. You may be able to go back in and fix it. So with these ones, make sure that the patient has stabilization, give them fluids, help them breathe if they're having a hard time breathing, maintain their body temperature. In a clinical setting, you might also start giving them vasopressors, which are medications that will make their blood vessels constrict. They're vasoconstrictors to counteract that distributive shock of the widespread dilation. And the last kind of distributive shock is anaphylaxis. We don't often think of this as somebody going into shock, but these widespread massive allergic reactions cause vasodilation across your body. So as they dilate, you're going to have fluid leaking out, so you might have swelling, you're going to have hives or rashes, and it's treated with epinephrine. So you can give the patient an EpiPen, and usually the symptoms will start to go away. You're essentially making the nervous system do the opposite of what it's currently doing. You're going to see things like a drop in blood pressure. They might have difficulty breathing, a weak pulse. This is really serious, so you do want to get them to the hospital as soon as possible. But it's nice to know that we do have the EpiPens to control the spread if you are ever caught out in the real world with somebody having an anaphylactic reaction. So the very last part about shock that we're going to talk about is the idea of compensation versus decompensation. So like I said at the very beginning of the lecture, normally your body tries to fix the problem. It notices that something's going wrong, so maybe it'll try to increase your heart rate to pump more blood around. If you're in that stage right after the shock starts, you're going to be in what's called compensated shock. You're going to try to make up for the problems. Eventually, though, your body's just going to be too depleted of its resources. It's going to be struggling far too much to compensate, so you enter decompensated shock. You're not, you no longer have enough energy to maintain all of the normal functioning, and you start to crash. This can occur very quickly. So the patient might be sitting there talking to you perfectly fine, and then all of a sudden they crash. And it's hard when they get to this point, because they can crash and you can still have time to fix it, or they might have reached a point called irreversible shock where they literally do not have enough energy to keep their body alive anymore. And pretty much no matter what you do, there's so much organ failure in their body that they're probably going to die, and there's nothing you can do about it. So this deep compensated shock can last minutes. It can happen right before the patient goes into irreversible shock. So it's always better to really take a good history and make sure that your patient doesn't get to the point of decompensated shock if possible. All right, I hope you guys enjoyed it. Let me know if you have questions.